The deep dive. Today we're taking a bit of a shortcut to getting really well informed about some crucial yet often overlooked players in our digestive system. We're zeroing in on organs vital for digestion and the conditions that, well, they can cause significant discomfort and often need careful management.
That's right. We're going to embark on an in-depth exploration, really, of disorders affecting the biliary tract, that's your bile ducts, and also the gallbladder and the pancreas. These organs, they really work together, and understanding their common issues, inflammation, stones, even more serious conditions, it's incredibly important for recognizing what your body might be telling you.
Yeah, and our mission today isn't just listing facts. It's more about unpacking the complex causes, highlighting maybe some surprising symptoms, and revealing the latest treatments for things like gallstones and pancreatitis. The idea is you'll walk away not just with a clear understanding, but also maybe those aha moments, connecting the dots between symptoms that seem unrelated and their underlying causes, helping you feel truly well-informed. We've got a stack of detailed sources here to guide us. So let's get started.
Okay, let's dive right in then. The gallbladder. It's that small, sort of pear-shaped organ tucked right under the liver. What actually happens when it decides to, well, act up? What are the main culprits?
Well, the two main issues we'll focus on are cholecystitis, which is essentially inflammation of the gallbladder itself, and cholelithiasis, which just means you have gallstones, the primary cause for both. It often boils down to an obstruction. So imagine a small stone, or less commonly, maybe a tumor, blocking the exit for bile, that digestive fluid from the gallbladder.
When that bile gets trapped, it acts like an irritant, you see. And that leads to the inflammation, the cholecystitis. Or sometimes a stone can block one of the larger bile ducts instead, causing what we call obstructive biliary disease.
So it's not just having the stone, but the blockage it causes.
Yeah.
That makes perfect sense. Who's most at risk then for developing these gallstone issues? Are there sort of common threads in the sources?
Absolutely. Our sources point to some pretty clear contributing factors. These conditions, they tend to be more common in females, particularly American, Indian, or white individuals. Also, people who are obese or pregnant. We also see a higher risk in what we call multiparous women, so those who've had multiple pregnancies. And also the use of birth control and, importantly, a diet that's consistently high in fat.
Right, the dietary link. Makes sense given bile's job with fat. So for our listener, how would they even know if their gallbladder is the issue? What are the key symptoms we should really be aware of? Because, lots of digestive things feel similar.
That's a really good point. The clinical signs can be quite telling once you know what you're looking for. A lot of people start with general indigestion, nausea, maybe some vomiting, especially after fatty foods because, like you said, a fatty meal triggers the gallbladder. But a hallmark symptom, something to really pay attention to, is severe cramping pain in the right upper quadrant, the RUQ, upper right side of the abdomen. We call it biliary colic.
Biliary colic, okay.
Yeah, and this pain, it often starts in the RUQ, but can quite uniquely radiate. It might go to the back or the right shoulder blade, even the right shoulder itself.
That specific pain pattern, RUQ, radiating to the back or shoulder, that sounds like a really important clue. What other signals might the body send out?
Well, beyond the pain, you might notice a loss of appetite, maybe dark amber urine, or stools that are clay-colored and fatty. We actually call those fatty stools staturia. Other signs, maybe less specific but still relevant, can include things like flatulence, an increased heart rate or breathing rate, diaphoresis, that's just excessive sweating, maybe a low-grade fever, and an elevated white blood cell count, which points to infection.
Right.
And in more severe cases, you might even see jaundice, a yellowing of the skin or the whites of the eyes. That's from elevated bilirubin levels, a clear sign that bile flow is blocked somewhere.
That's a really comprehensive list. And those specific pain patterns and visual changes like jaundice really stand out as red flags. So once these suspicions are raised, how do doctors go from a hunch to, a definite diagnosis? What's the main test that helps them actually see what's going on?
Right. So once symptoms point towards the gallbladder, one of the key diagnostic tools mentioned in our sources is something called endoscopic retrograde cholangiopancreatography, or ERCP for short. It's basically a procedure where a provider guides a thin, flexible scope with a camera and endoscope down through your esophagus and stomach to look directly at the bile ducts and pancreatic ducts.
Wow, so they can actually see inside.
Exactly. It allows for direct inspection, and they can even sometimes treat the problem right then and there, like removing a stone if they find one.
So it's diagnostic and therapeutic. That's fascinating. Okay, so once a diagnosis of, say, cholecystitis or gallstones is confirmed, what's the usual plan? Are we talking immediate surgery, or are there steps before that?
Well, initially, the medical management often focuses on resting the system and controlling those acute symptoms. So that typically means keeping the patient NPO nothing by mouth. They'll also get IV fluids for hydration, bed rest is important, and sometimes an NG tube, a nasogastric tube, might be used for suction to relieve pressure.
Right, settling things down first.
Yeah, exactly. Medication-wise, we're looking at antispasmodics and analgesics for the pain, antibiotics if there's an infection, and antiemetics for the nausea and vomiting. Our sources also mention specific bile acid dissolvers, drugs like Actigol or Sodiol. These can, over time, actually dissolve certain cholesterol gallstones. But it can be a long process, sometimes up to 2 years, and requires a really strict low-fat diet.
2 years, wow.
Yeah. And another non-surgical option, though less common now, is lithotripsy. That uses shock waves to break up the stones from outside the body.
So quite a few non-surgical options, potentially. But what's considered the most definitive treatment if those don't work, or if it's a really severe case?
In many situations, especially with recurrent symptoms or severe inflammation, cholecystectomy, which is the surgical removal of the gallbladder, is generally the preferred treatment. And nowadays, laparoscopic cholecystectomy is the standard. It's minimally invasive, smaller cuts, shorter hospital stay, much quicker recovery compared to the older open surgery.
That's definitely good news for patients. So let's say someone has had that laparoscopic surgery. What does recovery usually look like? And what sort of adjustments might our listener need to make afterwards?
Post-op, one of the first things is getting up and moving around, gently gradual ambulation. This actually helps a lot with the shoulder or upper back pain that can happen from the gas used during surgery. It's also really crucial to watch the incision sites for any signs of infection or dehiscence. That's when a wound might reopen.
Okay, important checks.
Absolutely. And patients should immediately report any signs that might suggest a bile leak, things like ongoing nausea, vomiting, unusual pain, or if their abdomen feels distended. Heavy lifting is a no-no for a while. Diet-wise, it usually progresses pretty quickly from clear liquids back to solids. And stool color typically gets back to normal brown within about a week, though some initial diarrhea is pretty common.
And what about long-term diet changes? Is life totally different without a gallbladder?
Well, for the long term, dietary adjustments are definitely key for many people. A low-fat diet is generally recommended to make digestion easier. So that means cutting back on rich dairy, fried foods, chocolate, nuts, heavy gravies, that sort of thing. Avoiding gas-forming foods can also help things like beans, cabbage, cauliflower, broccoli, just while your system adjusts.
That makes sense. Now, this brings up an interesting point about specific things after surgery. Our sources mention something called T-tubes. What are those, and what's important to know if someone has one?
Right, T-tubes. They're sometimes placed after surgery, especially if there was a lot of swelling or maybe stones removed from the main bile duct. It's basically a tube shaped like a T that helps drain bile externally while things heal. If you have one, key things are measuring and recording how much drains over 24 hours, making sure the drainage bag is kept below the gallbladder level, gravity helps here, and ensuring the tubing isn't kinked or blocked.
Okay, so gravity's important.
Very. Keeping the patient sitting up quite high in what we call high Fowler's position also helps drainage. Wound care around the tube involves changing the dressing daily, and showers are usually better than baths to lower infection risk. And critically, you should not try to irrigate the T-tube or clamp it unless a doctor specifically orders it, or raise the bag above the abdomen. That could cause bile to back up, which is not good.
Got it. No messing with the tube.
Exactly. It's usually removed once tests show the bile duct is clear and bile's flowing normally into the intestine, and then you just monitor the site for infection.
That's incredibly detailed, very helpful for anyone going through that. Okay, so we've navigated the gallbladder. Let's pivot now to its neighbor, the pancreas. What happens when it gets inflamed? Pancreatitis, right?
Precisely. Pancreatitis. It's an inflammation of the pancreas, and it can be acute, sudden onset, or chronic, like a long-standing problem. Our sources are pretty clear that alcohol consumption is a very, very common cause, unfortunately. But it can also come from trauma, infections, certain medications, other conditions like really high triglycerides, or, yes, those gallstones we just talked about.
The gallstone connection again.
Yep, especially if a stone gets lodged down in the common duct and blocks the flow from both the gallbladder and the pancreas. Abdominal trauma, getting older, even sometimes complications from that ERCP procedure we mentioned can trigger it. That gallstone link is definitely a key connection between these two systems.
So a gallstone really can cause double trouble. How would someone know if it's their pancreas acting up this time? What are the telltale symptoms of pancreatitis? And how might they differ from the gallbladder pain?
That's a crucial distinction. The pain of pancreatitis is often really intense, typically felt in the epigastric area that's upper central abdomen, just below the ribs. And it can radiate, often straight through to the back, or maybe to the left flank or left shoulder. It's usually worse when lying flat on your back. And importantly, it often flares up after eating or drinking alcohol because those things stimulate the pancreas to release enzymes.
Okay, so the pain location and triggers are a bit different, more central, radiating back, worse lying flat, and after eating or alcohol.
Yeah.
What else might someone experience?
Other common symptoms overlap a bit: lack of appetite, nausea, vomiting, just feeling generally unwell, malaise, maybe a low-grade fever, and jaundice is possible too if a stone is blocking the bile duct. You might also see a site that's fluid building up in the abdomen or maybe absent or decreased bowel sounds. Skin might feel warm and moist.
Oh.
But what's really fascinating, and often a clearer sign of pancreatitis, are some unique physical findings. Our sources describe Turner's sign, that's bruising, ecchymosis on the flanks, the sides of the abdomen, and Cullen's sign, which is a bluish-gray discoloration around the belly button. These are quite striking signs of internal bleeding or inflammation.
Wow, bruising on the flanks or near the belly button. That's specific.
It is. And another important sign relates to calcium levels. Pancreatitis can cause low calcium hypocalcemia, which can lead to tetany muscle spasms. You might see Trousseau's sign or Schwastek's sign, which are ways doctors test for that irritability.
Those visual cues, like the bruising, are really striking. So when doctors suspect pancreatitis, what do the diagnostic tests usually show?
Diagnostics typically reveal significantly increased levels of serum amylase and lipase. Those are the key pancreatic enzymes we measure in the blood. Bilirubin might be up too. You'll also often see a higher white blood cell count, showing inflammation or infection, and sometimes because the pancreas also handles insulin, you might see hyperglycemia or high blood sugar.
Right. Given how painful and serious this sounds, what's the medical approach? How do you manage pancreatitis and give the pancreas a chance to heal?
Well, management primarily focuses on controlling symptoms and, crucially, resting the pancreas. Pain control is paramount, often needing strong analgesics. Patients are usually encouraged to find the most comfortable position, often that's sitting up and leaning forward, or maybe curling up in a fetal position, because lying flat usually makes the pain worse.
So finding that right position is key.
It really helps. Resting the gut is vital too, so often NPO status again, to reduce pancreatic enzyme secretion. 4V fluids are essential for hydration. An NG tube might be used if nausea is bad or the abdomen is distended. We monitor intake and output really closely, often checking urine output hourly, and vital signs are checked frequently, usually every 4 hours, to watch for changes.
And what about other medications or interventions? Are there specific drugs used?
Yeah, besides pain meds, antiemetics for nausea are common. Anticholinergics might be used sometimes to decrease secretions, but cautiously, especially in older men with BPH, because they can cause urinary retention. H2 blockers or PPIs, proton pump inhibitors like Tagamet or Pepcid, are usually given to prevent stress ulcers, which can happen when the body is under this much stress. Antibiotics are used if an infection is suspected.
Okay.
In really severe cases, we might use hyperalimentation or TPN, total parenteral nutrition. That's feeding intravenously, completely bypassing the gut to give the pancreas maximum rest. If surgery is needed later, say for gallstones, then post-op care involves encouraging coughing and deep breathing hourly. If gallstones were the cause, an ERCP might be done to open up the sphincter of Oddi, or a cholecystectomy might follow. And in some chronic cases, there's a procedure called a Roux-en-Y to reroute pancreatic fluids directly into the small intestine.
That's a lot of complex ways to support the pancreas. For someone dealing with chronic pancreatitis or maybe pancreatic insufficiency, what's the long-term advice, medication or diet-wise?
For long-term health, especially if the pancreas isn't making enough enzymes, that's insufficiency, then enzyme replacement medications are key. Drugs like pancrelipase, Creon, or pancrease, these are taken with meals to help digest food, especially fats. So monitoring stool consistency, looking for less fat, is important. One caution: these often contain pork products, so a pork allergy is a concern.
Good to know.
Vitamin supplements are usually needed too, especially the fat-soluble ones A, D, E, and K, because fat absorption is often poor. And critically, for chronic pancreatitis, avoiding all alcohol is absolutely crucial. It just further stimulates and damages the pancreas. Diet-wise, the recommendation is usually high calorie, high protein, but low fat.
So what does this all mean? It's clear pancreatitis is serious business. Let's just briefly touch on pancreatic cancer, which our sources also mention. What's the difficult reality there?
Pancreatic cancer is, unfortunately, often diagnosed quite late, which makes it very challenging to treat successfully. The exact cause isn't always known, but our sources list several significant risk factors. These include cigarette smoking, exposure to certain industrial chemicals, having diabetes, chronic pancreatitis itself, a diet high in red meat, fat, maybe coffee and alcohol, and obesity. It can also spread from other cancers' metastasis.
That late diagnosis sounds incredibly tough. What are the key signs or symptoms someone might experience, even if they're subtle initially?
Yeah, the symptoms can be quite vague at first, making early detection hard. Things like anorexia, losing your appetite, ongoing fatigue, nausea, maybe flatulence, those clay-colored stools again if the bile duct is blocked. A persistent, dull, aching pain in the epigastric area, maybe similar to pancreatitis, but just sort of always there. Significant, unexplained weight loss is a big red flag. Jaundice, of course, the new onset of diabetes. And ascites, that fluid buildup.
And treatment options.
Treatment is complex. Pain management is key, often requiring opioids like morphine. Chemotherapy is used, with gemcitabine or Gemzar often being a first-line drug for the common type, adenocarcinoma. Sometimes antispasmodics like probanthine are used to try and decrease pancreatic activity, but they have side effects like dry mouth, constipation, confusion. Surgery, like the Whipple procedure, a really major operation removing parts of the pancreas, intestines, stomach, gallbladder, bile duct, or even a total pancreatectomy, is the main potential cure, but only if it's caught early and hasn't spread.
A very complex surgery.
Extremely. And often, chemotherapy and radiation have limited effectiveness, sadly. So palliative care focusing on symptom control and quality of life becomes a really, really important part of managing pancreatic cancer.
Wow. That was a truly comprehensive deep dive. We've covered a lot from gallstones all the way to pancreatitis and pancreatic cancer. It's clear how interconnected this whole biliary tract, gallbladder, and pancreas system really is.
It really is. And if you connect it to the bigger picture, what stands out is how one seemingly small issue, like a gallstone, can potentially trigger this cascade of events, inflammation in the gallbladder, maybe then the pancreas, and, even increasing long-term risks. It just highlights the delicate balance in our digestive system and how important it is to recognize the signals when something isn't right.
Absolutely. Understanding these conditions isn't just about, learning facts. It's about appreciating how our bodies work and being tuned in to the signals. So for you, our listener, what stands out most from our chat today? Maybe it was a symptom you hadn't heard of, or a risk factor that resonated, or perhaps a detail about treatment. Think about what you've learned and how it might shift your awareness of your own health. Maybe encourage you to listen just a bit closer to what your body might be telling you. Thanks so much for joining us on this deep dive. Until next time, keep that curiosity alive.